Hello, everyone, and welcome to our webinar series on understanding MACRA and the Quality Payment Program, otherwise known as QPP. My name is Sharon Phelps, and I will be your moderator today. Today's session will cover the scoring and submission methods for the Merit-Based Incentive Payment System, commonly referred to as MIPS. Here are a few housekeeping items before we get started. First, this webinar is being recorded. This recording and the others in the series will be made publicly available in the coming days on the www.healthinsight.org/QPP website for your reference. And we're going to put that in the chat box so you have that. The slides are available right now for download on that same website, www.healthinsight.org/QPP. Scroll down the page and you'll find a webinar link near the bottom. And if you click on that, you'll find the slides there. We are using the Zoom platform and believe you will find it easy to use. All attendees have been muted to prevent distracting background noises. At any time during the webinar, you can ask a question by clicking on the Q&A button at the bottom of the Zoom window. These questions will be answered by our team of Quality Payment Program experts. Additionally, you can use the chat feature to share your thoughts, comments, and questions with the entire audience. This too will be monitored by our team and brought into the Q&A portion of today's session. Lastly, at the end of the webinar today, we respectfully request your feedback on how we did and how we can improve. Watch for a survey link in the chat box and please take a moment to fill it out. That's very important for us and really helps us be able to deliver education that you can use. Thank you. Dave, can you go to slide number 2? We are pleased to offer this series as a collaborative effort between Health Insight and Mountain Pacific Quality Health with the goal of bringing education and understanding to empower clinicians to thrive in the changing healthcare environment. Health Insight and Mountain Pacific are quality innovation networks funded by CMS to provide quality improvement services. Health Insight is the quality improvement organization for the states of Nevada, New Mexico, Oregon, and Utah. Next slide, please. Mountain Pacific Quality Health is the quality improvement organization for the states of Alaska, Hawaii, Montana, Wyoming, and the territories of Guam, American Samoa, and the Commonwealth of the Northern Mariana Islands. Together, these two organizations are teaming up to support providers and clinics through healthcare redesign in both delivery and payment systems that better align payments with the outcomes sought: best care, best health, and reasonable costs. And now, I'd like to introduce you to your speaker today. David Smith is a Health Information Technology Project Manager for Health Insight Oregon. He manages the Oregon Quality Reporting and Hospital Value-Based Purchasing Program education and quality improvement initiatives, in addition to managing the Quality Payment Program educational assistant initiatives provided to all practice sizes in Oregon from the Oregon QIO. He also has worked in executive positions for EHR companies in marketing, sales, and operations management roles. Dave has an MBA from Westminster College and a BA in English from Brigham Young University. With that introduction, David, you may begin.
All right, thank you, Sharon. So, first of all, I'm just going to give you a quick overview of what we plan to cover today. We'll be going over scoring for MIPS and submission for MIPS. So under the scoring, we'll be talking about the quality ACI, or Advancing Care Information, improvement activities, and costs, which are forthcoming. And then we'll also be talking about submission via solo, group, and group strategies, as well as strategies for selection of which methods you choose and timelines. All right, so for scoring for MIPS, the breakdown is 60% for quality. 60% of the score goes to quality, 25% to advancing care information, and 15% to improvement activities. For 2017, 0% of the score goes to costs. So we will be going over a quick review on what we think is coming for costs, but keep in mind that this is still being decided. A lot of it has been discussed. The comment period is over for that section. Also, I don't know if any of you have taken a look at the 2018 proposed rule, but there are some new suggestions in there as far as how costs will be scored as well. So here's the MIPS pie. Again, for 2017, 60% to quality improvement activities are at 15% and advancing care information for 25%. So it makes sense to focus your efforts on quality. This pie may look different depending on different methods you might be using to submitting, or if you're not required to submit advancing care information, that piece of the pie goes away if you're a non-patient facing MIPS provider, but this is in general what it looks for most providers. In 2018, this is how it will change. The costs will be inserted into 2018 is the likely scenario at this point where that will affect 10% of your overall score. For 2019, that cost part of the equation will bump up to 30%. Again, for performance of MIPS, the performance as far as it relates to your score overall for MIPS does not affect your pay for an additional 2 years in terms of your Medicare reimbursement. But it's important to consider that and understand that so that you take the MIPS program seriously as it will affect how you get reimbursed. So let's talk about a sample. This is just a sample scenario for a provider. So if he or she was, or that group was submitting their measures, they would be submitting quality, ACI, and improvement activity measures. So with quality, there are multiple methods for scoring, but there is a 100% limit in terms of that's the total points you can score. For ACI, you'll notice there is a 100% limit as far as how much of that part of the score applies to your overall score, but you can actually overscore in this category. So it makes sense to overscore so that you, at a minimum, hit that 100%. That should make it very easy to score and do well in that area. For improvement activities, there are a couple different ways that you might report on that if you're in a large clinic or a small clinic, or if you're in a rural area. Large clinics and those that are not in rural areas are required to submit 40 points worth of improvement activities. That will get you to 100%. Smaller clinics do 20. And so, but again, that contributes to a 100% score. So you can see how, so let's say that the actual score for this particular provider was 50 points, and that applies to, so that would be 50% of the total score. And the weighting is 60 in terms of what the weighting is for 2017. That provider will get 30 points in that category. For ACI, you can see how if this provider scored 115 points out of 100, again, the limit is 100%, and the weighting would be 25, so they would get 25 points if they scored 115. If you scored 50, then obviously that would take that down to half of 25 points, which would be 12.5 points. For improvement activities, let's say that they scored 20 out of 40. They're required to do at least 40 points. That would put the percentage at 50%. So half of 15 would be 7.5. So the overall score for this particular provider would be 62.5. I'll be talking a little bit more about the scoring. I thought it would be helpful to share this up front, just to let you know, first of all, that it can be a little bit confusing, and so pay attention to the next few slides so that it will help you understand the scoring a little bit better. So quality scoring is based on benchmarks set up with deciles. There are 3 points for submitting each measure, and up to 10 points per measure if you're in the 10th decile for a particular measure. You should take a look at the benchmarks document on the qpp.cms.gov website. If you're going to be choosing your measures, it's a good idea to choose ones that you know you can at least make some improvement on and that you can have some good scores on. You may also want to consider the relevance to your discipline or specialty. You can also get extra points for high outcome and high priority measures in addition to the 6 measures. Again, you can't score higher than 100% in any particular area, but if you are short of that 100% based on the measures that you're submitting, you might want to consider reporting additional outcome or high priority measures. Again, you have to include at least one outcome measure to be considered for full points for 6 measures, or at least 6 measures. So let's talk a little bit about deciles, what they are and what they are not. Decile could be anywhere on the spectrum from X plus 0% to X minus 100%. A quality measure reporting at 45% is not necessarily in the 4th decile. 45% could be in the 3rd decile or the 8th decile, depending on the performance of others. So here are some examples of scoring quality in MIPS. Let's say that you had a particular quality measure like A1C control, poor control, and you were in the 3rd decile. You would get 3 points towards the MIPS quality measure. You get 3 points just for submitting the measure again. So whether you're in the 1st or the 2nd, you get 3 points. So if you're in the 1st decile, you get 3 points. If you're in the 4th decile, you get 4 plus points. 5th decile, you get 5 plus points. 8th decile, 8 plus points. Again, if you're in the 2nd decile, you get a minimum of 3 points. Just want to reemphasize, just for submission, you get 3 points for submitting any measure. So let's talk a little bit about poor control of A1C. So here is an example of the deciles for poor control for hemoglobin A1C. You can see that if you were at 15% and you submitted using the claims method, you'd be in decile 6. For the EHR method, you would also be in decile 6. But if you were using the registry or QCDR method, you would be in decile 9, so you get 9 points. So it's very important to consider which method you're using to submit, whether it's claims, EHR, or registry, QCDR. You want to make sure that you are using standards that will support your overall quality goals and keep these scoring methods in mind. So if you're submitting solo, you must submit 6 or more measures. Many claims-based measures are topped out. So if they're topped out, or you can only score 3 points or 4 points, but you can't score 5 to 9 points because the ranges of those deciles are so small or high performing that you can't perform. You may want to consider using other measures. Also, we suggest, again, using these benchmarks. Consider using custom QCDRs or qualified clinical data registries if clinically relevant. And ideally, make sure that when you talk to the QCDR, ask them, are 20 providers submitting the measures? That's a minimum requirement for quality measure submission in order for benchmarks to be set. So if the QCDR has more than 20 measures and benchmarks are created, that gives you the opportunity to score higher on that measure than just 3 points. Not all measures in each specialty measure set will be applicable to all clinicians in a given specialty. So if a specialty measure set includes less than 6 applicable measures, the eligible clinician should only report the measures that are applicable. So here are the different specialty measure sets. You can go onto the QPP website and pull down, this is a filter, if you take a look at the measures that are available for reporting. And here, for example, if you're an electrophysiology cardiac specialist, there are only 3 measures. So you do not need to submit 6 measures if you're an electrocardiac specialist. You can just submit these 3 and still get full credit. You won't need to submit the minimum of 6, which is required for everybody else that has more than the 6 available measures. So let's talk about quality again. If you're in traditional MIPS, quality counts towards 60% of your total score. It may be lower if you're an advanced alternative payment model where costs may also count towards your overall score in 2017. So if you're, for example, there are a few states on the call that have the CPC plus AAPM. I believe that they have a lower percentage for the overall total quality score, where you have a cost part of the equation for your advanced alternative payment model. So next, let's talk about scoring advanced care information. There are 3 components: core, performance, and bonus. It's 25% of your final score in 2017. It promotes patient engagement and the electronic exchange of information using certified electronic health record technology. And it replaces the Medicare EHR incentive program. There's greater flexibility in choosing measures. And in 2017, there are 2 different measure sets for reporting. So if you're on a 2014 certified system, you can use your 2014 system for submitting measures. However, there are also reporting requirements for if you're on a 2015 version. We'll go over those different methods now, or in the next few slides. Again, there's a maximum possible of 155 points. 100 will get you to the full 25 points as part of that part of the MIPS score. So again, here you have a base score of 50 points, performance of 90 points, and a bonus of up to 15 points. You can choose to submit up to 9 of these ACI measures for a minimum of 90 days for additional credit. For bonus credit, you can submit public health and clinical data registry reporting measures as well. For the base points, so you need to perform each of these with a yes, no, or at least 1 in the numerator or denominator to demonstrate participation. So let's take a look at the left side here. If you're on a 2015 certified product, you need to do a security risk analysis, e-prescribing, provide patient access, send a summary of care record, and request and or accept a summary of care record. So if you have 1 in the denominator for these bottom 3, that gets you credit. You get the full 50 points. This is an all or nothing thing, so you have to do all of them as required, depending which method you're going to submit for it or which type of product you have. So if you are on a 2014 certified product, again, you need to do your security risk assessment, do e-prescribing, provide patient access, and do electronic health information exchange. So again, this is for people who are on a 2014 certified product. That product alone doesn't have the ability to measure these 2 options: send a summary of care record and request accept summary of care record in the way that they need it to. So that's why they've broken it out into 2015 and 2014. It's just 1 item for health information exchange. For the performance categories, you'll notice that some of the items on the prior list are on this list. For example, provide patient access, send a summary of care record, request accept summary of care record. All 3 of these are part of those core. So you can get double credit for these as long as you're performing. So you get a point for each 10% of performance you are into that measure. So if 55% of your patients have access to your patient portal for the records done during that period of time that you choose, then you can get 5 points. You would need to be at 100% to get or 90% above 90% in order to get a full 10 points. For if you're on a 2014 product, you can see how these points break down. So you get double credit if you're on 2014 for patient access and health information exchange. So it's kind of a 2-for-1 if you're on a 2014 product. Anyway, so just keep that in mind. You get up to 20 points. If for example, you're getting 50%, that would get you 10 points for patient access on this one. So again, the rest of the advancing care information items are on here, and we've had other prior webinars to discuss that in more detail. If you want more information, you feel free to contact us and we can share more information on that. So for bonus points, you can get you can report to 1 or more of the public health and clinical data registries, submit syndromic surveillance data, do electronic case reporting. You can also report certain improvement activities to get an additional 10 points. So you get 5 points for these top sections, 10 points for these items below. And again, this is on the right side here is the 2014 and 2015 requirements over here on the left. They're just slightly different. Here you can see public health registry reporting as opposed to clinical data registry reporting. For improvement activity scoring, you get you'll need to score or have an opportunity to score 40 points for groups of greater than 15 providers, and 20 points are required for groups of less than 15 providers. High activities on, if you're looking at the 90 improvement activities on the QPP website, high scoring areas get 20 points. Medium improvement activities get 10 points. So let's talk about a couple of scenarios. Larger groups will typically have several improvement activities happening in their system. You might have some of your providers doing one improvement activity in one corner and another one in another corner. You get credit for your whole group as a 10 for the improvement activities that are happening. So you'll want to consider that as you're submitting and determining which improvement activities you want to use for MIPS. Finding improvement activities that are supported by 1+ providers give credit to the whole group. You get full support if you're in a patient-centered medical home, such as the NCQH model, or for a state-based PCMH if it's approved, such as like Oregon's PCPCH program. So again, let's go back to this sample a little bit. I just want to point out a few things here. Hopefully this is a little bit more clear at this point. When you're looking at your quality measures, you want to look at the measures you're submitting, see how you're performing in those deciles, and determine what your score is overall. And you can do that today. You can figure out where your scoring is and figure out exactly how that's going to be scored today. For ACI, you'll want to take a look at the different areas, your core, your performance, and your bonus categories, and figure out how you're performing. You can figure that out today as well. Improvement activities. Take an inventory of the improvement activities that are going on in your organization, or take a look at the list if you are a smaller provider, and consider which ones that you might want to consider joining. And then that will help you figure out what your overall score is. There are different calculators online that you can get access to. You may want to consider evaluating one of those. We can provide access to some of those calculators. Feel free to contact us. We'd be happy to get those to you. So the next topic is submission methods. There are group and solo submission methods for the MIPS program. Your tax ID number may be choosing a method for you. So if you're in a large group, you might want to consider asking the question, how is my MIPS data being submitted for me? And if you're working in multiple TINs, or if you have your own clinic aside from employment for a larger healthcare system, you may want to report for each TIN, as it will affect how you get paid. Providers moving from other TINs may utilize reporting from that other TIN as they move to another organization. So if a provider moves into your organization and has worked somewhere else for 80% of the year, their score that is submitted on behalf for them through that other TIN may affect your overall score as well, depending on how you're submitting, especially if you're submitting via individual or solo options. All right, let's move on. So let's look at different submission methods. So this is a really nice graphic that kind of helps you understand how data might be submitted by your organization. And we'll talk through one or two scenarios. So let's say that you're a solo doctor. You can submit with your EHR for quality. You can attest to advancing care information and type in those numbers. And then you could also use your attestation for improvement activities. If you are in a group of greater than 25 providers, you could report all three of your areas under quality advancing care information, but you could also use another method for submission. Let's say you wanted to do quality through the web interface, advancing care information through attestation, and improvement activities through your qualified registry. So there are ways of doing that as well. So currently you can mix and match between these different categories, but not within the category. So if you're going to submit quality measures, as it is for 2017, you can't both do EHR and QCDR. Now, you could register for one of these methods and then choose not to do it and submit through another one, but you will have to choose ultimately one method for submission. For group providers, the CMS web interface is only available to groups with 25 providers or more. QCDR is also available for group providers. Qualified registry is also available. You can also submit using your electronic health record. Keep in mind with your EHR, you will want to talk to your EHR vendor and find out whether or not you will be typing in the numbers yourself, or they will be submitting it for you through an API or directly to CMS for you. You want to have a clear understanding with your EHR provider which method you're using if you plan to go that direction. For CAPS, if you're going to submit CAPS for your quality, you can also submit that if you're in a group with 2 or more clinicians. And for attestation, you can use you can only submit advancing care information or ACI and improvement activities for that method of submission. So again, just looking at this same submission slide again, you can take a look at this and just kind of see how you might mix and match these, or sometimes there's a big advantage with just choosing one. If you're a specialist and let's say you're an ENT doc, there's a really great registry called REG-ENT that I know a lot of ENT doctors are using. It's through their academy, specialty association. They can submit, I believe they can submit quality, advancing care information, and improvement activities, all 3 of them. But you will want to be careful. If you're in a QCR that submits 2 of these but not another one, you'll have to choose another method for submitting that particular category. So again, looking at some strategies for selection, you can only use one submission method per category in 2017. It's possibly changing to multiple methods per category in future years per the 11-day-old proposed rule on the 2018 MIPS. You can find more information on that at CMS if you think you might want to go that direction in 2018. But for 2017, again, you can only use one submission method. So timelines, 3 days from now is June 30th. That is the deadline for registering for CAPS and for the web interface. So if you're thinking you might want to do one of those methods, as if you're in a large system for the web interface greater than 25 providers in your tax ID, then you might want to consider that. If you're in a smaller group and want to submit, or larger group and you want to submit CAPS as a quality measure, then you want to consider that deadline as well. You'll need to submit for that very soon. So let's talk about the different methods and some things you want to look out for. For the QCDR, Qualified Clinical Data Registry, if you're using a custom measure or registry measures, confirm that enough providers will report. The magic number is 20 providers. That will help you create benchmarks. Also evaluate the value of submitting more measures to your organization and to your specialty area. So if you're in a specialty where you would like to help your specialty create more information, you may consider, only scoring 3 points on a measure for the sake of working with your organization or your academy to start to further the science of what you're working on. But you'll want to take that into consideration, that it may also affect your overall score. If you're doing ACI, make sure that you confirm that your chosen QCDR supports submitting ACI. Some of them do not. And also confirm that they can submit the improvement activities for you. This is a list of QCDRs that you might want to consider using. It's a very exhaustive list. Almost every academy is represented in there for different specialty associations. And in some cases, if your specialty or academy association is not represented, they may have created some sort of a connection with another vendor that is helping them with quality measures. Measures submitted may not be official MIPS measures, but can count. So again, consider appropriateness to your specialty. And I covered a little bit of this on the prior slide, getting ahead of myself a little bit here, but you can get a score higher than 3 if there are over 20 people submit. But there again, so anyway, just big advantage if over 20 submit. All right, let's talk about the qualified registry. If you're using customer registry measures, confirm that enough providers will report. Again, that does apply to this. With the qualified registry, the difference here between the qualified registry and the QCDR is that these measures can be created by your organization. You also want to confirm that benchmarks are available and evaluate the value of submitting more measures to your organization and to your specialty, again, if you want to work on the science of what your academy or organization is working on. For ACI and improvement activities, again, confirm that if you're using a qualified registry and you're using them for all submission methods, that you can confirm that they can submit those items for you. One other thing you may want to consider, if you're using measures that support state-based initiatives, there might be some benefits to you. For example, many states have alcohol and substance abuse measures that they submit to their Medicaid groups, and these measures often are required for reporting. So if you want to focus on measures that support that, or your state-based measures, there are some advantages to doing that, to reduce the burden of reporting on your organization. If you're using an electronic health record for submission, you'll want to evaluate the measures that you can submit. There are a lot of advantages with using your EHR. One of the most obvious is the real-time access in many systems to that data. Depending on which EMR provider that you're using, you might be able to take a look at those measures on a daily, a weekly, or at least on a minimum of a monthly basis to see how you're performing, so you can track your progress on those measures. So again, a lot of advantages to that real-time data. Again, some vendors don't always support that. Also, some vendors may share in mutual benefits of improving quality, and you want to consider measure submission benefits to performance rankings in benchmarks. Some of those EHR systems are better at showing you what those benchmarks are. You can always download the Excel spreadsheet off the QPP website to see what the benchmarks are yourself. Some vendors I've heard are looking at implementing and integrating those benchmarks right into the system, so you can see how you're performing overall as it compares to other providers in the country. I think the only difficult area for this would be improvement activities. I'm not sure how that will work with your EHR providers, but again, you'll want to confirm with your EHR provider that they are submitting on your behalf, or that you need to submit on your own with you using this method. For administrative claims data is another method for submitting quality. If you're just trying to avoid the penalty, then you can obviously submit on one patient on one measure, and you get credit for doing MIPS. You avoid the 4% penalty. So you can use the administrative claims method for doing that. You want to know the trigger code is for the denominator, and for the numerator, make sure you understand how to indicate that quality measure has been done for at least one patient. If you want to perform all year long, you would have had to have been starting this in January through the end of December to perform well on this measure, to have a complete data set. So you want to take that into consideration as well. If there's any question as to where your quality's at, you may want to consider using a registry if you want a more accurate representation and want to score more than 3 points on your measures. Using the attestation method, you'll be able to submit ACI and improvement activities. Consider the probability of error if you're going to attest when you're typing in the data, make sure you get that data right, and do your own quality check. Have someone look over your shoulder to make sure you do it correctly. Also, it's helpful if one or if this method can be helpful for using the attestation method if you have more than one electronic health record and you have to combine scores from various systems for the ACI measures. For improvement activity, consider data validation to support improvement activities. If audited, there is a data validation file that you can download off the QPP website. For web interface, for quality, there are 15 measures. For ACI, there are vendor submission options, so you'll have to work with your web interface vendor to determine how that information is going to be submitted with them. And for improvement activities, they have the ability to support improvement activities using this method. So again, work with your vendor, figure out what they would like to do. So I think that's it. The next webinar for my slides, we are going to have some Q&A, and we also want you to fill out the information. We've got a review of our webinar. We'd like you to provide any feedback if at all possible. There will be another webinar on how to improve your score on July 11th, and you can register here at this website. And let me see, should I turn the time over to you, Sharon?
You sure can. Thank you, David. Okay, we're going to have our question and answer series, and we have already gotten some questions from you, so we appreciate that. I am going to give the first question, and Aaron or David, if you can discuss the answer. So the first question we had was, if we have 4 family care clinics participating in CPC Plus, which is about 45 to 50 of our 300 plus providers, does this change how we report MIPS, or do we still report quality, ACI, and improvement activities? It appears that CPC Plus participants only report ACI and improvement activities.
Well, I think that would depend on, I think I know which group this might be, and it might be Debbie, right?
Yep.
So, okay. So you'll want to submit ACI for your whole group and improvement activities for your whole group. You could decide to do web interface and submit the 15 quality measures for your entire group as well. Your CPC Plus program may require reporting of certain quality measures. I know I don't know the CPC Plus program inside and out, but I believe if you're above the 80% percentile mark, that that qualifies you for certain incentives within that program, from what I know. So anyway, does that answer your question? I would report your whole 10 for all providers, and you could mix and match the different groups. You could do quality for your, you could choose the web interface for your quality. You could choose attestation for ACI and improvement activities if you wanted to.
Yeah, and I'd echo that. I think that web interface, the group web interface, is a really good option in that case where you have so many providers. Yep. For the quality.
And I know Debbie, you've been considering that, but thanks for asking.
We do know that when you report quality for those providers who are not part of CPC Plus, but are subjected to MIPS, that you are allowed to include your CPC Plus providers when you come up with your performance results for those quality measures. Yeah,
no need to break them out.
Yeah, that's helpful. Okay, our next question. Is there a CMS fact sheet that details all the scoring options for all the categories, or do you have to go to each category fact sheet to get that information?
Let me read that.
And I don't know if any of my fellow panelists have ever seen one of those. I personally have not. There are a number of webinars out on the QPP webpage that will go over things like for Medicare shared savings or APMs, and they'll go into the specifics for that particular scenario. But I've not seen a fact sheet that lays out all the different scoring options side by side. So we'll keep looking for that one, because that's a great question and would probably be helpful for a number of folks.
Yeah, agree.
Okay, our next question. Is it possible to report as a group for 30 out of 35 ECs, but for the remaining 5 ECs to report them individually?
It's my understanding that you choose, if you're doing group submission, that you're choosing for your 10 once you choose to report as a group. And so at that point, you'll be submitting for that for your organization. That's what I understand. I'll defer to some of the other panelists to correct me, but that's my understanding.
Yeah, you know, Sharon, I would be interested in your comment on that too. My understanding too is if they report 2 different methods, CMS will just take whichever one is the highest. So if somebody did do group and individual, however they scored higher, they would take.
My understanding, David, is that if you are reporting at the group level, that group is for all of your providers. You can't split them out. Now, if you have a small enough group that you could report at the group level plus report individual for, you know, say only 3 or 4 providers. I've not seen what David says where they would look and see what is more favorable for you. I do know if you submit more than the required number of quality measures, they'll pick the quality measures that are most favorable for you. What I've seen is that you either do everybody's in the group or everybody's individual. You can't break folks in and out of the reporting, the way you're reporting for 2017.
Oh, interesting. Okay. Yeah. I mean, that would be a good question maybe to run, it's a very individualized question to run maybe by CMS or the help desk,
Yeah.
because
We can certainly do that.
yeah, we can do that one.
Okay, the next question. Can an organization report for all eligible clinicians under 110 as a group for quality and improvement activities, but then report as at the individual level by individual basis for the ACI category? Our understanding for that one is you have to use the same method for all of the categories. So if you report group in 2 categories, you need to use group in the 3rd category, or vice versa. If you report individual for quality and improvement activity, then you need to do individual at the ACI level as well. So it's the same across the board. Okay, next question. What kind of documentation would be required for improvement activities that require quality measures to be tracked? Do you simply attest, or is more documentation needed?
I think that's where you want to look at the data validation file for the particular improvement activity and look at the specific things that the data validation document recommends that you keep on file.
Yeah.
So
yeah,
go ahead.
Yeah, I agree with that. And Aaron put in the response the link to those data validation criteria. So, yeah.
Let's put that in the chat just in case not everybody can see those questions.
You know, there was another question, Sharon, right above that one. And the question was, what about organizations that are part of an ACO? What are the requirements for reporting MIPS measures? And it really, and the answer that Aaron gave, and I thought was a good one, is what type of ACO you're on. And because there's a list that you can find on the QPP website of the advanced APMs. And if your ACO is an advanced APM, then you're kind of on a different track. the majority, though, of ACOs right now, of folks that are in ACOs, will fall under MIPS. So, I mean, it really, so the reason Aaron's kind of, trying to dig a little bit deeper there is it really depends on the type of, the way the ACO is structured and what kind of advanced payment model.
Okay, I think
Sharon and David, we've got another question on the open Q&A. Where the person asks, where do I get the attestation forms for advancing care information and improvement activities?
Okay, and it's my understanding that you will do attestation online, and that system is not yet operational or available.
Yeah, that's my understanding also. So it's, we haven't actually seen an example of that yet, but that'll come in coming months.
What we've been told is that it's like a yes/no attestation where you will indicate which improvement activities you did, then what you need for your audit file, because we know, just like meaningful use and PQRS, that CMS can and does do audits of that validation guide we put in the chat box. That will give you information that you want to keep in your audit file. So if you ever get audited, you can prove that yes, you did a given certain activity, and you have your documentation proof there. You will not necessarily need to provide it when you attest, but if you do get audited, you want to have that available.
Thank you very much.
Okay, do we have any more questions?
I wanted to make one last statement while people are asking. So one other thing to consider with the money that's being paid out for MIPS, there's also a $500 million pot that will be distributed to clinics that score over 70 points for MIPS, and to tax ID numbers that score over 70 points. I didn't include that in the presentation, but that is part of the MIPS effort. So if you're on the borderline at 68% and you're wondering if you should push a little bit more to get over 70, I would definitely do that. Again, that will be a pot that will be distributed up to 10% of your Medicare revenue, but the pot is 500 million. So if it's used up, if a lot of people get over 70 points, then that pot will be smaller and may be smaller than the 10%. But one thing we saw with PQRS and the value-based modifier is that some clinics got quite a bit of money for their quality performance and their cost performance, because not a lot of groups participated or attempted to excel in that area, and so there were some clinics that really benefited from that. So just something else to consider.
Hey David, this is Aaron. I was wondering if you could maybe explain a little bit more detail about the test submission period. I've had several physician offices ask me about the test, how to do that.
And I actually don't know a lot about that at this point. Sharon, do you know anything about the test submission period?
The test submission is not so much a period as it is you actually are submitting some data.
Right.
It's your entry into the program. So for example, you can submit data for a single quality measure and that meets the test criteria. Now, obviously,
okay.
A number of, you have to look at each quality measure. Some of them look at, more than one data point. So, if sometimes that's 6 months, sometimes that can be something different. So if you pick one of those, you may not have the data you need to send it in for a shorter time frame. So the test is not really so much time bound as it is what the requirement in whichever category you're using is.
Yeah. And one comment and clarification there, this is for if you're submitting your quality data just from yourself. I mean, if you're pulling it from your EHR and you're pulling the data files to submit up through CMS's portals, there's some test options to be able to test that submission to make sure it's you know,
acceptable. Yeah.
Acceptable. I mean, in a lot of cases that Dave was talking about today, if you've got a registry doing it for you, or your EHR vendor is going to do it all for you on the back end, or you know, you've contracted with someone to do it, then those testing and validations will happen with those entities that do that submission.
Thanks for that clarification, David. That was helpful. Kim, our host, has posted the survey, so we really would like you to go ahead and take that survey and let us know how we've done today. We appreciate your feedback. That is helpful. Before we end the session, Aaron, Brock, David, do any of you have any questions that you've seen that we haven't covered today?
I have one. A client is going to be changing EHRs on July 1. Any recommendations for them as they're going into it?
Wow.
That's a great question. You know, that can be handled a couple different ways. One, if they already are tracking quality measures, tracking their ACI criteria, they could have gotten a 90-day time frame in before July 1st. And if they save that data, put all of that data in their audit file, they may have everything they need to attest a 90-day time frame before the new system. The same thing's true on the backside. They may want to pick a 90-day period after they've gotten a little more comfortable with their system, and just use data from the new system instead of from the old system. If they're really into excelling, they can try and use 365 days, which would be combining data from both systems. That would be a Herculean effort. But if they're doing really well, perhaps it's worth it for that extra bonus pot of money over 70 points, as David mentioned earlier.
Yeah, you know, a couple of comments on that too. Whenever you're changing out an EHR, the mapping from your data components is really key, and making sure that the database underneath your old EHR is matching well to your new EHR. But beyond that, a lot of that depends on kind of if they're looking for a certain type of functionality for reporting on MIPS, and the vendors are very different on their approaches on how they do this. I mean, some of it's very do-it-yourself, and some of it is we do it for you, and so a lot. If they're looking at changing HR based off of functionality too, just make sure they're clear on kind of how this new vendor handles quality reporting to CMS.
Very good, thank you.
We just had one more question. Will the slide presentation be available? And the answer is yes, it currently is available on the www.healthinsight.org/QPP website. Go ahead and scroll to the bottom of the page and you'll see a link to webinars, and the slide deck is already out there. We'll have the recording posted in just a couple of days when it's ready. Okay, Brock or Aaron, David, anybody else have additional questions?
Thank you.
No, none.
Okay, well, I want to thank everybody for your time today. We're going to give you a few minutes back early. You had great questions in the Q&A and in the chat. We appreciate you attending our webinar today, and we hope to see you at some of them in the future. Have a great day. This concludes our webinar.